afternoon. Thank you for allowing me to present here on behalf of Kafle University School of Medical Sciences. Today I'm going to present about our small clinical research which compare the anticipated pain, which is not the real pain, but the pain anticipated by the patient before the treatment started, and the real pain experienced by the patient after some procedures. That is the comparative study, and as being an orthodontist, I will do that on the orthodontic patients. I come from the land of Himalayas and land of yogis. They don't care about life, they just stay in the temples and do some yoga and very relaxed, some people. And it's land of multiple cultures and multiple ethnicities. This is Nepal. And this is the place, this is the Google map, and this whole area is the university. Our university was started in 1996, inaugurated by our late king. We started with a very small building. Now we have expanded a little bit, and the expansion is going on so far. And you can see this is the dental block we have, and this is the academic dental block. This is our future dental school, but now we are up to this level. I think in my slide we are still, there was last year's photograph. We completed to now 2 floors still to be completed. Okay. The pain has been defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Okay, but pain, in my experience from the clinical point of view, is a very complex thing. And in terms of mechanism of orthodontic pain, the orthodontic procedures will reduce the proprioceptive and discriminative abilities of the patient for up to 4 days after the starting of the orthodontic treatment, and that results in lowering of the pain threshold and disruption of the normal mechanism associated with the proprioception input from the nerve endings in the periodontal ligament. What happens after we apply any orthodontic force? It's always hard to define how much is the optimal orthodontic force, but still we apply from 35 gram up to 200 gram, or sometimes even in orthopedic force it goes up to 450, more than that also. But when we apply force, there is occlusion of the blood vessels, then there is transient ischemia, and that releases the neurotransmitters and messengers, and that activates second messenger, and that differentiate different bone formation. That causes tooth movement. But the mechanism of pain is a little bit different. The injury to the tissue or tissue damage that releases the bradykinin serotonin, as we all know, and it activates or sensitizes the nociceptors, and it releases the substance P, and it acts on the mast cell and degradation. Then it releases histamine, and that causes the excitation of the neurotransmitters, and that is transmitted into electrical signal through the spinothalamic part, and it is perceived as a pain. This is same theory which is represented in figure, but we apply force, then there is transient ischemia, of course, and there is mild acidic environment is created, and that causes pain. Some people have very low pain threshold, some people have very high pain threshold, and some people have continuous pain, and that is described by the neuronal plasticity. It's nothing but it is the adaptive change in the neurons and neurotransmitters, and repeated exposure to the stimuli, that the plasticity can decrease the body's own pain inhibitory system, and which results in ultimately in increased pain. And the injury, inflammation, and the disease can all cause neuronal plasticity and increase pain by means of increased excitatory and decreased inhibitory activity. We have three types of stimuli, of course: thermal stimuli, mechanical stimuli, and chemical stimuli. And that is changed into electrical signal and perceived as pain. And these stimuli change into electrical stimuli by a vanilloid receptor VR1. This is the pain pathway, the noxious stimuli. It is passed through the spinothalamic tract and perceived as pain. From mouth, it should not be only orthodontic pain. It can be other dental pain also. From side, is it? So the pain, it's really dependent upon age, gender, individual pain threshold, the magnitude of the force we apply, the emotional state and the stress, cultural differences, and previous pain experiences. In orthodontic point of view, people always think orthodontics is a very painful procedure. The research has shown that up to 95% of the orthodontic patients experience some sort of pain during orthodontic therapy. It is one of the major reasons for not willing to go for orthodontic treatment because of the fear of pain or because of the complexity of the pain. And it is the reason for discontinuing even the orthodontic treatment. It is most hated side effect of the orthodontic treatment. There are other biological side effects like apical root resorption, then sometime bone loss also. And this is one of the major fear before starting the orthodontic treatment. What I mean to say is that patient anticipate pain even before starting the orthodontic treatment. And people usually do not want to or do not wish for treatment because of the fear of pain. The orthodontic treatment comprises of different stages, starting from the first visit to the orthodontist, followed by diagnostic different investigations, then pre-banding visit, bonding, every month archware activation, debonding, then followed by retention also. The first painful experience patient will have after placement of the separation. Those people who had banding, they really think that this is very, very painful, and we don't pay much attention for this procedure. And after banding also, it's like on the gingival tissue we are pushing something for another 2 or 3 years. I don't think it is that much comfortable. And another important visit is very crowded teeth or malaligned teeth, and we start giving force. We claim light is better, but actually we do not have instrument to measure how much force this wire is giving. We think it is minimum, but still it is more than 35-40 gram of the force. And that is also continuous force, and that starts causing the pain. And of course, debonding, debanding visits. So the objective of our research is that another colleague of mine who is not present, she was also involved for this, is to compare the anticipated pain and pain experience among the patients undergoing for comprehensive orthodontic treatment. The methods, we selected total 80 patients going for comprehensive orthodontic therapy, and they are given the BAS scale. It's 100 millimeter visual analog scale, and it starts from 1 to 10. The 0 is no pain at all, 1 is the minimum pain they had, and 10 is the maximum bearable pain they could have. The patients are requested to report the degree of pain they anticipated or experienced on the scale. The scale is 100 millimeter with marking 0 to 10. As I explained this one, the patients are requested to note the pain they anticipated before treatment and real pain experience after each orthodontic treatment. Actually, it's a little bit longer research one, where we have asked the patient to measure the pain after 1 hour, 4 hours, 12 hours, and after 1 day. Some results: the anticipated pain and the pain following bonding. Okay, there is a statistical difference between anticipated pain and the pain after bonding. Means that you can see in the table that the anticipated pain is really higher than the real pain experienced by the patient. These are the breakdown of the pain related things. Anticipated pain after the putting separator, pain after bonding, and pain even after extraction.